Hi there, we concluded the first part of this talk by discussing the extrinsic muscles of the hand. We now come to the intrinsic muscles. As mentioned, these are small muscles that arise and insert in the hand. They are the muscles that control and produce all the fine movements of the hand. From a practical point of view, it is helpful to consider the intrinsic muscles in three groups. Firstly, the thenar muscles which control the thumb. Secondly, the hypothenar muscles which control the little finger. And thirdly, the intermediate muscles which are the main abductors and adductors of the fingers, as well as producing flexion at the MP joints when the fingers are in extension, and extension at the IP joints when the MP joints are flexed. We need to give this last function of the intrinsic muscles some thought, as was discussed in the fifth talk in the series on ulnar nerve lesions. When the MP joints are in flexion, the long extensors cannot function because the extensor belly is stretched. So the only way you can extend your fingers is by using your intrinsics. Similarly, when your fingers are in full extension, you cannot use your long flexors to flex the MP joints, and the only way you can do this again is by using your intrinsics. All the intrinsic muscles that move the thumb, with one very important exception, are supplied by the median nerve as shown here, namely flexor pollicis brevis, abductor pollicis brevis, and the deep muscle opponens pollicis. The only other intrinsics supplied by the median nerve are the lateral two lumbricals. You possibly remember the mnemonic from your anatomy days, one of the few that can be used in public, namely LOAF, the lateral two lumbricals, opponens pollicis, adductor pollicis brevis, and flexor pollicis brevis. The two median nerve supplied muscles that we test for are the abductor pollicis brevis and the opponens pollicis. All the rest of the intrinsics are supplied by the ulnar nerve. I did mention that there is one very important intrinsic muscle of the thumb not supplied by the median nerve but by the ulnar nerve, and that is the adductor pollicis shown here with the superficial muscles removed. The muscle arises from two heads and inserts into the base of the thumb, and which we will test for very specifically. By the way, it is worth noting that the index finger has 7 muscles, 4 extrinsics and 3 intrinsics that control its movements. See if you can work them out. So how do we test for the 3 nerves that supply the hand, namely the radial, the median and the ulnar nerves? And recall that the radial nerve does not supply any intrinsic muscles. From a practical point of view, I'm going to suggest 9 tests for motor function, 3 for the radial nerve, 3 for the median nerve, 3 for the ulnar nerve. So for the radial nerve, the 3 tests are, firstly, we test for power of wrist extension. With a radial nerve lesion, one will have absent or weak wrist extension, so get the patient to extend the wrist and try to overcome this. Secondly, we test for finger extension, and remember it must be done with the MP joints in extension, otherwise, as we know, when the MP joints are in flexion, the intrinsics can extend the fingers. So with the MP joints in extension, press on the dorsum of the proximal phalanges in an attempt to flex them. Thirdly, a good test for extension of the thumb is the anti-gravity test. Place the hand flat on the table and get the patient to lift the thumb towards the roof, and this movement can be resisted. For the median nerve, 3 tests. Firstly, test for opponens pollicis by getting the patient to pinch the tip of the thumb and the little finger together and try and overcome this. Secondly, test for abductor pollicis brevis. I get the patient to place the hand in supination and lift the thumb towards the roof, and I do this against resistance. And always check for wasting of the thenar eminence. Here's an interesting question. If one has a low median nerve lesion with loss of function of abductor pollicis brevis, why can't you simply abduct the thumb using abductor pollicis longus, which is supplied by the median nerve higher up? Think about this and I'll give you the answer shortly. For the ulnar nerve, again, 3 tests. Abduction of the fingers, as we've suggested. Get the patient to fully abduct the fingers and try and resist your attempt to overcome the abduction. I always test specifically for the abduction of the index finger, as this gives you the opportunity to see and palpate the bulk of the first dorsal interosseous muscle. In severe ulnar nerve lesions, this muscle wastes dramatically, as shown in the slide. And here you can see the wasting of the first dorsal interosseous with clawing of the ring and little fingers in a case of ulnar nerve lesion. Secondly, the adduction of the fingers, as we described earlier in the first part of the talk, and the importance of keeping the hand flat on the table. In testing for adduction of the fingers and also the thumb, which we will describe shortly, I prefer to use a manila folder rather than a piece of paper, which I find is too thin. And thirdly, testing for adduction of the thumb, which, as we know, is supplied by the ulnar nerve. The function of this muscle is to approximate the pulp of the thumb to the index finger, as in the key grip. This test we do is to get the patient to hold firmly onto a piece of paper or cardboard with both hands, while the examiner does likewise, then ask the patient to try and prevent the examiner taking the paper away. Where there is normal function of the ulnar nerve, the patient will be able to hold the paper firmly. However, in an ulnar nerve lesion, where the function of the adductor pollicis is weak or absent, the patient will attempt to hold the paper using the long flexor of the thumb with flexion at the IP joint of the thumb. This is known as a positive Frohman's sign. It is worth noting that in testing for adduction of the thumb as suggested, you will see that the IP joint of the thumb is held in slight flexion. Test this on yourself. This is due to the action of flexor pollicis longus, as if this did not happen, the IP joint of the thumb would simply go into hyperextension. So the long flexor stabilizes the IP joint, so giving maximal power to the adductor pollicis. So to revise, for the radial nerve, we've got extension of the wrist, extension of the fingers, and extension of the thumb. For the median nerve, we've got opposition, we've got abduction, test for the wasting, thinner muscles. For the ulnar nerve, we've got abduction of the fingers, we've got adduction of the fingers, and we've got the adductor testing for Frohman's sign. And now testing for sensation. This slide shows the commonly accepted sensory innervation of the hand, although there is some variability. As noted, the ulnar nerve supplies the medial 1.5 digits, both front and back. The median nerve supplies the rest of the front of the hand and also supplies the dorsum of the lateral 3.5 digits to the level of the PIP joints. The rest of the dorsum of the hand is supplied by the radial nerve. Despite the variation in sensory supply, there are what are called autonomous zones, which are those areas very specifically supplied by a particular nerve. For the median nerve, it is the pulp of the index finger. For the ulnar nerve, it is the tip of the little finger. And for the radial nerve, it is the web space on the back of the hand between the thumb and the index finger. As with sensory testing in general, and as was discussed previously, this needs to be carried out slowly and deliberately. The patient needs to understand what you are doing, needs enough time to consider and respond, and the testing often needs to be repeated with cross-checking. My preference is to use a K-wire with a bent end so that it doesn't roll away and the sharp end is not sharp enough to draw blood. Here's another question to think about. How can one test for sensation in the hand of a patient who is unconscious or a child who is too young to understand? And finally, testing for vascular function. The blood supply of the hand is via the radial and ulnar arteries. The radial pulse is readily palpable, the ulnar pulse less so, but can be felt just lateral to the tendon of flexor carpi ulnaris. Keep trying until you are confident that you can feel it. Here you have the radial artery and the ulnar artery, and you can see how the two arteries communicate freely by the superficial and deep palmar arches, and this is readily demonstrated in the Allen test. So what we do, we occlude radial and ulnar arteries, get the patient to open and close a few times. Okay, leave it open, you can see how the hand blanches. Release the ulnar artery and you can see how the hand perfuses well. Then do the same again, open and close, and leave it open. See the blanching, open the radial artery, and you can see how the perfusion occurs. In answer to the first question then, when one has a low median nerve lesion and has lost the power of abductor pollicis brevis, why can't one simply abduct the thumb using abductor pollicis longus, which is supplied higher up in the arm? The answer is that abductor pollicis longus does not really function as an abductor of the thumb, and this is a misnomer. It acts more as a stabilizer of the base of the thumb and can assist in flexing and abducting the wrist, but has minimal, if any, abductor function of the thumb. With regard to the second question of any ways to test for sensation in the hand in a patient who is unconscious or too young to understand, here are 3 suggestions. With nerve damage, one also loses the autonomic supply of the fingers and loses the power of sweating. As a result, the pulp of the affected digits or digit will feel dry compared to the unaffected normal fingers. Telling the difference requires patience and practice. Secondly, the violin test. For the same reason of the above, when there is normal sensation and sweating, when one runs a smooth plastic pen over the digit, one will feel a slight resistance because of the moisture. When the skin is dry, there is much less resistance. Try this out on yourself. Then place a little bit of tissue over the end of the finger and see the difference. Interestingly, this is particularly noticeable in the little, ring and middle fingers, but less resistance in the index finger and the thumb. And thirdly, the prune test. If you have ever spent a lot of time in the water, you will notice how the skin of the palps of the fingers tends to wrinkle. This does not happen in the denervated digits. The mechanism is thought to be due to vasoconstriction, and there is much discussion as to the evolutionary reason for this. Once again, thank you for your attention, and I hope that you will join me for the next talk in the series on the hand. Until then, Salani Gashli.